Welcome, my name is Isaiah Ailes. I'm a recent medical school graduate. In today's video, I'll be providing an overview of how to understand a chest radiograph with emphasis on key information for medical students for their clinical rotations and boarding exams. As a forewarning, the information provided in this video is intended for medical students and healthcare professionals and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Also, I wanted to note that the cases we will be looking at are found for free publicly on Radiopaedia, so thank you to all the contributors who uploaded the cases. So let us begin. So just to orient ourselves, I'll try to have the clinical presentation here, and then we'll have our chest x-rays here. So this is a chest x-ray, also known as a chest radiograph. And let's start with the anatomy. So we can see the humeral head here, and then we can see the acromion, and then it meets the clavicle, come across, same structures. You can see the coracoid process here, the superior and inferior angles of the scapula, medial and lateral borders of the scapula as well. You can see the lung here. This is the left lung, and this is the left hilum. This is where the left pulmonary artery and vein enter, as well as the left mainstem bronchus. And these little structures that are flaring out, you can see here, that's all pulmonary vasculature. Those are not the airways. Those aren't bronchi or bronchioles. And then as we go more inferiorly, you can see this is what is known as the costophrenic angle, costo being the rib, and then phrenic being the diaphragm. And right next to it is the gastric bubble. It's important to take notice of it because sometimes it can clue us into some pathology. And then we can see here as we come up. So let's start from the base. I guess is the apex of the heart here actually. And then this would be the left ventricle going to left atrium. And then you can see the aortic knob here, which is the ascending aorta going across to becoming the descending aorta. And then as we go up here, this is the trachea, this dark tube-like structure. It's full of air as it should be, and that's why it looks dark, just like the lungs, full of air. And then you can appreciate here, there's a bit of a darker line, whiter line, and that is known as the paratracheal stripe. It is known as the paratracheal stripe because it's next to the lung, and so you can see this nice, beautiful boundary because there's two different densities. Densities are two structures with the same density you can't really appreciate as well. And we'll talk about that later with the silhouette sign. And so that is pretty much the overview there. And then this is the right mainstem bronchus, left mainstem bronchus, where it diverges is known as the carina. It's spelled and looks like carina, but it's pronounced carina. Something else I wanted to note here is that this 30-year-old female patient, you can appreciate the breast tissue. And most times, it's important to take notice of this because it can make the lungs look hyperdense. It can make it look like there's pathology when there really isn't. This takes time getting used to knowing when the lungs look hyperdense or too white, and that's part of becoming a radiologist or becoming a clinician in general. So let's move on to the next element here. I'm just going to refresh. And so for the quality metrics of assessing a chest radiograph, I like to remember the mnemonic peer map. Just everything I have here, you can choose any other way to remember it. So the projection is how the chest radiograph is taken. So if it's from a posterior to anterior, view, so it would be the x-rays coming from the patient's back to the front. For a PA view, the patient is standing upright with their arms kind of flared out, and their chest is towards the detector. And then the light is shooting behind them. And alternatively, AP is the light is shooting in front of them where their chest is towards the projector and their backs towards the detector. And that's important to note, and we'll show why in a second. Inspiratory volume, it could be reduced or hyperinflated, and that's going to change how the pulmonary vasculature appears. It will appear more crowded in a reduced inspiratory volume. Rotation depends on the patient's positioning. Sometimes for patients in the ICU, patients getting an AP image, they'll be positioned in bed. It may be hard to maneuver them otherwise, depending on sedation and whatnot. In terms of magnification, this is how the heart size appears on a PA versus AP view. And then there could be angulation as part, the same idea of what can cause a rotation as well. And lastly, penetration refers to the X-rays. So the X-rays can be, synonymously, we can say here penetration being strength. So the X-rays can be too strong or not strong enough. And that's the same idea with over penetration versus under penetration. And so we'll start with the first quality metric being projection and magnification. So you can see my lovely Nalgene bottle, not sponsored in today's video. So we can say if the Nalgene bottle itself is the patient, and we'll say like more specifically, it's their heart, and the wall is the detector, you can see this is what the image looks like. It looks almost exactly the same kind of height and pretty much size. And perhaps if I got the bottle a little closer, it might look more accurate, right? And that's the same thing for an image. And so what you don't see here is the light source coming in from the front here or from the side, whatever you want to call it, and projecting this image onto the wall. And then that's a PA view. And what we notice though, it does not magnify. So keep in your mind's eye what this looks like. And as we go to the next slide, you can see how much bigger it is by just moving the bottle back a little bit more towards the left. So if this were to be the patient, again, the detector, you'd see the heart looking more enlarged. And so the farther away from the detector, the image does become magnified. And that's why it's important to remember the projection of the radiograph, because it's going to clue you into whether something's going to be pathologic or not. So let's get our presentation. So a 30-year-old male motorbike accident. With that being said, so we can see here, this patient did receive an AP view. How do I know? It's always labeled. So if it's supine, mobile, portable, AP, those are all going to be synonymous. And with that being said, with the AP view, the heart looks much larger. Typically, we want to see the heart less than half the size of the from the midline to the border here. And so this would look like it occupies that space and it looks enlarged. So we'd call that cardiomegaly. In this situation, we know the limitation of this chest radiograph being an AP. It's unlikely that this patient actually has an enlarged heart. Additionally, you'll see that there is some pulmonary crowding, some pulmonary vascular crowding, and you can see here it's a little bit more accentuated and it kind of looks a little hazy a bit, but it's just more crowded. And we'll talk about inspiratory volume in a second, but let's see what happens when the patient gets a PA image. And my goodness, look at the difference. The lungs are completely different looking, and for it being the same patient, it's impressive to see how much different it is. On one hand, especially having a motor vehicle accident, this would be concerning, right? We'd be concerned about the wide and mediastinum. Maybe there's something going on in the lungs. And then come to find out, it's just the quality of the image. So that's important to take notice. Let's move on to, gotta refresh here. Let's move on to the inspiratory effort aspect. So this is a pediatric patient. Pull this back up. So 3-year-old male, you can tell it's a young guy. His bones aren't fused yet. But for inspiratory effort, the way we want to assess this is you can count the posterior ribs. So we have the first rib here, second, third, and then you can come across. When I say posterior, it's counting from 1, 2, 3, counting back here, versus anterior would be coming all the way around and counting these guys here. And you can see kind of where it ends. And you can see it gets a little challenging. So I always liked posterior for myself. So there's 1, 2, 3, 4, 5, 6, 7, maybe 7, 8 posterior ribs above the diaphragm. Typically, we want to see 9 to 10. So technically, we would say this is an image with reduced inspiratory volume. When you have reduced inspiratory volume, it makes the pulmonary vasculature look more crowded than it actually is. And that can make it confusing and make you think that there's some kind of consolidation or some kind of edema going on. And then if we look at the image with the patient with regular inspiratory volumes, we can see 1, 2, 3, 4, 5, 6, 7, 8, 9. So there's 9 posterior ribs. 9 to 10 is the goal, and you can see how it looks a bit more different, right? The pulmonary vasculature is a bit more stretched, and it's not as crowded. If you look here, it's a bit difficult to assess in this pediatric guy, but we'll see in the next case. So this is going to be our inspiratory image. So let's appreciate the ribs here. So in an adult patient, you can see maybe a little bit more challenging, but you can see the first rib, the second rib coming all the way across here, third rib coming across, and that's why it gets a little difficult to assess coming forward. So I like to go posterior. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 ribs above the diaphragm, and this is what the patient is presenting with. And this was read as normal. And then if you look at the expiratory view, or where the patient didn't have as much inspiratory volume, you can see it looks a little bit more crowded. And so just focus your gaze right here in this lower region. You can see how this was a bit more scrunched together and can look a little bit more pathologic. Alrighty, I'm gonna refresh that, I guess. And then in terms of our quality, so for rotation, let's appreciate what we have here. So this patient comes in and they had fallen off their garden decking, 65-year-old male. And so what we see here is that the patient is rotated a little bit towards the right. And how do I know that? It's because we look at the clavicle, right? The medial aspect here, you can see a little bit difficult to assess. Maybe if I zoom in a little bit here, you can appreciate the border there versus on this side coming off there. Let me back up. And so what happens is they're supposed to be equidistant from the spinous process, which are these little notches in the background, and that's going much more posteriorly, by the way. So they're supposed to be equal distance from each other. And you can see here, it's actually further this to the right. Sometimes you can look at the trachea. It's not really reliable because some pathologies actually skew the trachea to different sides. Anything that can cause increased pressure or mass effect. So a pleural effusion, pneumothorax can push it, atelectasis would pull it. So that's, just keep that in mind. Not the best utility for that. But you also can appreciate how the heart is actually moved more towards the right, or at least looks more towards the right. And you can see how knowing normal versus abnormal, you'd say, okay, well, this patient otherwise has a normal heart, but they're more skewed to the right. So that's important to consider in your quality. And so while this person had they're somewhat mal-rotated, you can see here also there's 1, 2, 3, 4, 5, 6, 7, 7 ribs here. And so everything's gonna look more crowded, right? It looks a little bit more pathologic, even though this case was read as normal. All right, let's see. So what we have next is penetration. So for penetration here, we'll talk about the strength of X-rays. So for here, you can see this image is very bright. It's hard to tell what's going on. Is it pathology? Like we don't know, right? It's it's an AP here, AP mobile, right? So we also know there's some other quality considerations going on. Aside from that, when we say the penetration, so you can say penetration synonymous with strength. So the X-rays are stronger, then the image is going to look darker, versus if the X-rays are quote unquote weaker, then it's going to look brighter. So this is underpenetrated, and we know that because the structures here are very bright. And so what I mean by that is the idea that when you have a very dense structure, such as bone, for example, it actually absorbs the X-rays. So what we're seeing here is the lack of an X-ray onto the detector, really. With that being said, you can also see here like all the soft tissue. Body habitus can change this as well, but we can't even see the heart. We can't see the spine, and we know the spine has calcium being bone, and we should be able to see it pretty distinguishable from the soft tissue of the heart, and we don't. And that's how you know, again, that the X-rays aren't going far enough or deep enough. And so you compare that to this patient, and you say, wow, there's a night and day difference, right? These X-rays are going too hard, too far. And the lungs, you can barely see what's going on. They're super lucent, being super dark, hypodense, Hypodense is dark. Hyperdense, you can see the midline structures, and you can see how something radiopaque as these markers and this device, you can still appreciate that, but everything else is just can't really appreciate it. And that's no good for determining if there's anything going on here. You wouldn't want this image to see if there's a mass or nodule, right? You would just say this is inadequate. So let's move on to normal anatomy in the lung lobes. So one thing when it comes to radiology is that radiologists want to be super systematic, right? A radiologist is responsible for everything on this image. If there was a little hyperdensity down here and it was a staple or something or a bullet or whatever the case may be, you would have to report that. That is part of a radiologist's job. So with that being said, they have a search pattern. And so for the next cases that we'll have, I'll try to go through a search pattern relatively quickly so we can save some time. But in medical school, they teach the idea of ABCD, ABCD approach. So you look at the airway, that's the A, and then next you look at the B, which is the breathing, which would be the lungs, right? You look at that, and then you look at C for cardiac, which would be the heart, and then D for the diaphragm, and then E maybe for everything else. Whatever the case may be. I personally don't like that approach for my own self going into radiology. I would prefer going outside in. So I like to look at the outside structures, something that doesn't require too much, not going to say effort, but when our main image and focus is here, I want to get these guys out the way. So I look at this first, and then I come down and I go back up systematically with my eyes. And then, I always check the cosophrenic angle here. And then I go across the diaphragm, and then I go back up and bounce back up and down. And then I'll go from the trachea and then just kind of zigzag, go across, look at the structures, look at the mediastinum, and then, check out the heart. That's the way I prefer to do it. Whatever works for you. As a medical student, you're probably just going to look at the pathology and see what's going on. But there will be some cases that I have lined up that you would actually need to appreciate the full image. So just keep that in mind, because you would be limiting yourself. If there was a fracture here and you're focused on a little opacity on this side, you could miss that. So that's something to keep in mind. And then the lateral isn't discussed much, but you can also appreciate some of the changes on here. And the anatomy is mostly the same, and I'll show you a couple images that will definitely help understand that. So let's talk about the lobes of the lungs. So this red is the right upper lobe, right middle lobe, and right lower lobe. You can see back here. The right lower lobe is also, the right middle lobe superimposes onto the right lower lobe as well. The left upper lobe, you can see, contains all these areas, and the lingula tends to be about here. So it's like almost a mimic of the right middle lobe, making space for the heart, and then the left lower lobe. So this is what the anterior aspect looks like, or the frontal view, I should say. From the lateral aspect, you can see that this is the right upper lobe, and then right lower, right middle. But you can actually see, if you were looking straight ahead, you can look here and say, okay, if there is an opacity, let's just say about here, some kind of consolidation or whatever, pathology, you wouldn't be able to tell if that was right middle, right lower. And so we have to be very strategic in how we approach that. And we'll talk about that a little bit later, actually very soon. And same idea here, if it's left, right lower or right upper, sometimes it can look blended, right, depending on how you look at it. And then let's go to the left view here. So for the lateral aspect for the lung, this would be the left upper, left lower. And you can see how pathology could be confusing because we have a 2D image, right? And it's hard to tell spatially if something's in the front, inside, behind. And this just highlights that aspect. So let's talk about pneumonia and the silhouette sign. This is how we're going to distinguish the lobes from each other. So first, let's take it to something that we actually know, something that's not abstract. So these were photos submitted to the Nat Geo Photo of the Year gallery by yours truly. And so this is a picture of the sky, right? We know what the picture of the sky looks like. It's not too confusing, okay? Now we have these next images, and this one in particular. How would you describe this? Would you describe it as a white continuous consolidation? Because if you did, then congratulations, you're a radiologist. But truly, how would you describe it? Right, it's white, it's fluffy. You know it's not supposed to be there, and that's pretty much like radiology in a chest radiograph. You'll see something that's white and fluffy, and might be pneumonia, it might be pulmonary edema, and we'll talk about ways to distinguish those later. And in terms of the quantity, you would say, oh, there's multifocal, right? There's multiple of these confluent or continuous opacities there. On the other hand, this image is a little bit more tricky, right? You can tell there's something here that's not supposed to be there. These guys, yeah, sure, we can see that all day, but something here is a little hazy maybe, right? It's not supposed to be there, but you really only know that this isn't supposed to be here because you know what normal looks like. This isn't blue, right? So that's how you would distinguish that. Now we go into the real words. So an opacity, right? So opacity is just anything denser than usual. In other words, sometimes it's a professional way of saying there's a thing, there's stuff, right? Sometimes we don't know what it is, so we say it's an opacity, an opacification, whether it's patchy, hazy opacities, and you can go from there. In terms of consolidation, tends to be focused on the alveoli are occupied with either pus, blood, exudate, fluid, whatever it is, there's something occupying the alveoli. That is the core definition of a consolidation. A cavitation, on the other hand, is a thick-walled cavity, and you'll see it tends to be outlined by more opacification, right? So there's a thingy around it, and then inside tends to be air, and that air is due to necrosis, whether it's infection, inflammation, malignancy. And the differential diagnosis for a cavity is relatively limited, mainly being lung abscess, tuberculosis, granulomatosis with polyangiitis, or squamous cell carcinoma, and there's a few others, of course, but these are some core ones that we think about. And then the silhouette sign. So very interesting concept. So what is a silhouette by definition, right? A silhouette is an outline. You think about your shadow, or you can see an outline around someone that's like kind of highlighted. And the silhouette sign is the loss of a border due to adjacent opacification. So you normally see borders around outlines because of the silhouettes, which makes this kind of confusing, right? Because it's a silhouette sign, meaning it's not there. So it's almost like silhouette sign sounds like it should be there, right? There should be a silhouetting, but the silhouetting out of a structure is the silhouette sign. So that means it loses its border due to some nearby opacification. Look at that. Back to my non-sponsored image. So if we look at the bottle here, we can see a nice sharp border, right? And it's because this sharp border is due to the plastic. The plastic's next to air, right? What's the difference between this being the trachea and this next to it, not the green in the background, but right next to the bottle being like a lung tissue, and then the bottle itself being the trachea? It's almost the same thing. It's like a paratracheal stripe. And now or you could say for the heart, for example, because in this image, if we put something next to it, right, you no longer see that silhouette. So this would be the silhouette sign. You lose that border, and that's very important in determining the location of pneumonia. So let's run into this. So for this, you can see here, pediatric patient. Again, you can see this from their bones, but we don't really see the right heart border a little bit superiorly. You're not really appreciating it well. Let's put this back up here. Chest infection and whatnot. And so you also see like the paratracheal stripe is not as sharp. I mean, you can kind of see it maybe if you make believe. And so this is what a right upper lobe pneumonia would appear as. On the contrary, you look at the other side, there is no pathology. And so remember, we had that image where it's like, oh, is it right upper versus right middle? Or if it's the superior aspect of the right lower lobe. And again, what clues us in is that you can't really see that paratracheal stripe here. Okay, so that'd be kind of losing that silhouette. And so let's get back into a systemic search pattern. So quick overall impression, you can see there's something going on here perhaps, but let's be systematic. We look at the clavicles, going across, nothing here, coming down, going back up, going across. This lung looks pretty fine. And then we come across here. The costophrenic angle is not blunted, and that's what a pleural effusion would look like. We'll see that later. And as we go across here, we see that there is some opacity, right? There's a thingy here. There's something here. And this thingy, because it's continuous, like that cloud, it's all together, it would be considered a consolidation. And we know that this is the right middle lobe and not the superior aspect of the right lower lobe, because you lose the right cardiac or right heart border, right? You're not seeing that border anymore. It used to be sharp, but you're not seeing it. And that's how we know, that's how we localize the pneumonia here. And then if we go to the, this CT will just confirm the location here being the right middle lobe. And we'll talk about CT in another video. Now this one is a little tricky, right? So we see here that this is the location of the right middle lobe. If we consider this, right, this would be the lung zone, lung region. But in this case, we see that the heart, you can see that border really sharply, right? That silhouette is there, so there is no silhouette sign, meaning the silhouette is gone. With that being said, this is actually a right lower lobe pneumonia. Typically in right lower lobe pneumonias, you actually lose the right diaphragm. It becomes hard to see, hard to visualize, and so that gets silhouetted out. However, this is the superior aspect of the right lower lobe. And so within each lobe, there's various segments. Won't go into that in this video, but with that being said, just because it's a right lower lobe, it doesn't mean that it has to be the entire lobe. That would be lobar. That'd be the entire lobe. This is rather segmental. It's the superior aspect of that right lower lobe. And then you can see on the left side, nothing to note here. Now let's move on to this case. So now this is another case of pneumonia, right? It's a right lower lobe pneumonia because we're not seeing that diaphragm. This is exactly what I was talking about. You don't see that diaphragm. You don't really see that right heart border anymore either, right? So it could be a right middle lobe pneumonia as well. And there's maybe some consideration of right upper lobe pneumonia. So this is pretty diffuse. And you see how it's all together. That's very classic of pneumonia. This consolidation here. And then on this side, perhaps you can see it's kind of together, but maybe it's pneumonia, maybe not. But again, it doesn't look as crazy as it does on this side. So this is definitely the focus here. And what's impressive is this is the patient when they were sick initially, and this is the patient afterwards. You can clearly see the difference, right? From the heart borders and even that little pacification in the right upper lung, right? Not there anymore. And then likewise down here. So, and also I want you to notice too, is that let's count the ribs. So 1, 2, 3, 4, 5, 6, 7, right? So this is a little bit more crowded, but this, although it's more crowded, this is just not the right kind of crowding, right? It's like that sky, there's something there. Maybe you don't know how to describe it, but there's something there, right? And then this kind of confirms it, but you can see how much more inspiratory volume this patient has. So keep in mind, any patient that's coughing, breathless, in pain, they're going to have a hard time keeping their inspiratory volume to an adequate level of a chest radiograph. Okay, so let's go to this. Now we're going to look at the left side. So if we look at the left image here, right, it's almost like this patient doesn't have a heart. And that's sad to say, right? So no, they do have a heart. It's just the fact that the pneumonia next to it makes it look like it's not there. And so that's why you have the silhouette sign of the left heart border, and this would be the left upper lobe. Particularly, you can say the lingula, because that's what hugs that area there. As you come down, you see the costophrenic angle is a little questionable and potentially blunted. So there might be a pleural effusion, parapneumonic effusion. On the right side, looks a little bit more sharper, looks a little bit more normal. Alrighty, and then we will talk about the lateral x-rays in a little bit. So this 80-year-old female, let's look what we have. So quick go across, not seeing any fractures here. Oh wait, we do see a fracture. Right, so that's why sometimes you want to keep in mind like what the patient is presenting as. I think they had mentioned this may have been like a subacute fracture. So it's already maybe already known, but nonetheless, you want to take note of that. You don't want to be the person who misses it. So we come down and we see here that the left costophrenic angle is blunted, right? It's hard to see. It's not as sharp. It's smoothed out. And typically in a frontal chest radiograph, it can hide up to a high volume of an pleural effusion. I believe anywhere from 250 to 500 milliliters even. It's very the frontal chest radiograph is very insensitive to it, and that's why we have to get a lateral or do an ultrasound, something that has a bit more ability to see those angles. Nonetheless, we can see there's an opacification here, right? There's something going on with, is it behind the heart, right? Because there's not much room in front of the heart, so there's something going on behind it, and it looks too dark, right? And again, this is why you need to know what normal looks like, because otherwise you may not notice this. And this is one of the key blind spots for radiologists. A key blind spot being behind a structure. Go to the right side, you can see it's the costophrenic angle sharp. Not too much to notice. You can see there's the pulmonary vasculature pretty prominent, but is otherwise normal, nothing to be worried about. And then we come down here and we can see there's nothing else to comment on from that aspect. Alrighty, and so then what about this patient, right? So we look at this patient and we see that the entire left side here of the lung is just full of something, right? It looks like it's full of something, but is it? Right? Because we can see the left diaphragm. We see it's also rounded, so there's some kind of effusion, but because we can see the diaphragm, we know that it's, if it were to be a left lower lobe pneumonia, maybe it's a bit more superior, but it's at very least a left upper lobe pneumonia, right? We don't see the heart at all. Not heartless, full of love, but otherwise hard to see. In this consolidation, you can see, you'll notice sometimes there's an air bronchogram, and that's just the airways within that consolidated material being highlighted because everything around it is so dense. Again, it's giving it a border. Same thing with the paratracheal stripe, right? It's giving it a border because there's something else near it that's not air, which it used to be, right? Because you don't see those air bronchograms on this side. Then we look across and we see there's nothing much else going on. Same idea, last one here. So let's go through our search pattern. We go across, we see the clavicles look fine, no fractures. We come down, we see this big consolidation. And what's interesting though is that the heart, we'd expect us to silhouette the heart, and it's a little interesting. I'm not seeing that, right? So we come down, and I haven't been talking about it because video would be too long, but we don't see that gastric bubble anymore. So that's interesting. But we come across the right side, and we do see that gastric bubble. And oh, by the way, the heart is also pointing in this direction. So what do you think could cause this? Right, so it would be situs inversus because the organs are flip-flopped, right? The gastric bubble should be on the left side, but it's on the right side. That's how we know it's situs inversus versus dextrocardia. If it was just dextrocardia, the gastric bubble would still be right below the left diaphragm. So interesting case, and just keep in mind, most people don't miss this just because it's so fascinating. And then the consolidation you can see there as well. Let's reload. All right, and so this was just the same idea. Now that we know all that consolidative material and that we were just looking at, we have the normal again, and now we were able to appreciate how this big old fluffy cloud in the lungs was making it difficult to see the normal anatomy. Now let's talk about this one, right? This one, we just know there's just something there. And in radiology, we call this interstitial opacities. And we'll discuss that in a little bit, but it has this hazy appearance, right? And I wanted to include this in today's topics because for atypical pneumonia, typically bilateral, by the way, you can see there's something more here. There's something going on. There's like some kind of hazy opacification, especially in this area, right? It's not so full-on fluffy cloud, but there's something definitely going on there. And if you know your normal anatomy, something's not right. And in this case, let's see what the indication was. 2 weeks of dry cough. I mean, that's almost like a layup. atypical pneumonia, right? Especially in a non-smoker. You have that long, prolonged history of cough, walking pneumonia as they call it. So you can see that bilaterally. And then we go across here, and then, same idea. So 15-year-old, same idea. And you can see that this kind of hazy opacification is different, right? It almost looks like the pulmonary vasculature, and this makes it so tricky. This was so hard for me to understand, because you just need to keep seeing what's normal, and eventually you cling on. But also note that it's important to have priors, right? If you don't have a prior, it's kind of difficult to know what should be present or what their normal looks like. But you can definitely tell there's something going on here. There's some kind of fluffiness, some kind of hazy opacification, not a full-on consolidation like the lobar pneumonia we're seeing. The silhouettes of the left heart and right heart border are pretty fine, and then the cosophrenic angle is not blunted, so it's something else going on, right? In the most clinical history, that makes sense would be that. And so let's look at this CT scan real quick. We won't talk too extensively about it, but you can see that there's all those opacities are coming into play, right? All that haziness, ground glass opacification is what we call it, and we'll discuss more about that in another video. Let's reload. All right, so spine sign. We haven't talked about lateral x-rays because nobody likes talking about them. But with this being said, this is a relatively normal chest radiograph, right? You can see it's super loosened, so something's already going on, but let's just focus on the lateral chest radiograph. To note, this patient doesn't have any secret hidden pathology in terms of pneumonia. And you can see here, what's really key is that when you look at lateral chest radiograph, particularly for medical students to take away here, is that the spine should be getting darker as you go down. It's the more black sign, or more black is what you'd expect. And that's because if you think about an image, you'd expect their scapula to be here, maybe the humerus, all their bones, and then as you come down, you lose all that density and you become more aerated. And that's why it's darker. Know that right behind the sternum, the retrosternal recess is supposed to be dark. That's fair. That's what it is. You can see the normal appearance of the heart, right? In comparison to one that maybe has pathology, you'll see that there's actually increased opacification here. And then right behind the heart, the retrocardiac recess is also supposed to be dark. And so the key takeaway for a medical student is that this spine should be getting darker as you go down. If not, there's something going on, potentially pneumonia. And then same idea for the retrosternal and retrocardiac spaces here. There could be some kind of consolidation appearing. And so let's take that concept and apply it forward. So we have this patient here. Let's look at the frontal. So chest radiographs go across the clavicles, no fractures, coming down. Okay, so the left cosophrenic angle, a little suspect. And then we go back up, nothing here, go back down. And then we see, this right behind the heart again. Is this too dense for my liking, right? And then we go back up, nothing too much else to note. This right cosophrenic angle is a little suspect as well. Then we come back up, come back down. Again, the pulmonary vasculature being prominent, it's not an issue. And we'll see a case when it is, but this is normal. And again, this is why you need to know what normal looks like. And then we come back up and go down, and we can see that the right heart border is somewhat displaced. So we would do a full, chest radiograph quality checklist. We would do our due diligence and check to make sure they're equidistant. And you can tell perhaps that's a little bit more skewed. Even just the positioning of the patient looks a little bit different. But nonetheless, and again, appreciate here the breast tissue, right? Because you can see look how it looks here and then right below it. This looks much more dense than it does down here. And again, that can make it look like there's pathology when it's actually not. What the key thing I want to demonstrate here is the fact that the spine does not get darker as you go more inferiorly, right? In fact, there's actually opacification here, and that could be a clue in for pneumonia. And let's see again where we thought. So right here is where we thought there was pathology, right? And then if we go here, that's exactly where it lines up in terms of the frontal view. If we were cutting this into a plane, you can see that there's something going on here. Retrosternal, fine. Retrocardiac, And I've seen darker, but there, it's some lucency. But the main finding here is this aspect of the spine. And then let's see what this is. And then this was the follow-up. So you can see here that the heart doesn't look as hyperdense, right? I mean, look at that. That's much different here, right? And then we look at the spine, and then the patient serves as their own control, right? It's dark, hyperdense, expected, and then it gets more black. That's, again, what we want to see versus the spine sign, which is when the patient has something here. Alrighty, so let's move on. So I think we're going to transition here to common pathology. So this is a bunch of cases that's somewhat ad lib in talking about the common pathologies that you would be expected to see, or that you would expect to see as a medical student. Most commonly see, I suppose. Now, this helped me tremendously. So when it comes to a chest radiograph, surprisingly, the differential is very vast. No questioning that. The technicality needed to understand it very high skill level. Sure. But what is something that we can grasp as medical students is that the pathology is fairly predictable. So when it comes to interstitial opacities, the appearance could be reticular, nodular, hazy. Think about that atypical pneumonia or that cloud I showed you. There's something there that shouldn't be there. It's hazy. It's not all continuous, right? That's what an interstitial opacity looks like. When it comes to reticular, it tends to be more interstitial lung disease. I'm not going to show that. It's a bit more advanced. Nodular can be somewhat same idea, and more so miliary tuberculosis is very common, showing the nodular appearance, or sarcoidosis. Consolidation, the differential is rather predictable. Again, things that I can grasp onto and bring with me to clinic: pneumonia, pulmonary hemorrhage, ARDS, pulmonary edema. ARDS being acute respiratory distress syndrome, right? So when we see consolidation, bam, this is what we go to. In terms of the atelectasis, it's the collapsed lung, and it could be due to an obstruction within the airways. It could be due to fibrosis. It could be due to adhesion. And this is more of a surfactant deficiency. Think about pediatric patients. Or there could be passive atelectasis, which can be due to pleural effusion. And then nodules and masses. Nodules are less than 3 centimeters, less than or equal to, and then masses are greater than 3 centimeters. And those appear fairly well circumscribed, well rounded. The way I like to remember this is I can, right? The other mnemonic that we had was PIR map, PIR map for quality, and this is I can for the lung pathology. And so we're going to see more pathology involving the chest radiographs and lungs, but this is particularly the lung pathology. So not pleural space diseases, but lung pathology. So quickly, let's talk about the pleura. So to understand a pleural effusion, pneumothorax, right, it's the potential space, the parietal space. It's a potential space because it's not truly a space. There's actually fluid there, and there's not much more room to it than that. But in pathology, you can see an increased space. So that's why it's a potential space. So visceral pleura hugs the viscera, right? So viscera being like typically like the intestines and all the other tissues. So visceral pleura belongs to the viscera. And parietal being peripheral, P for peripheral is how I like to remember it. And then if we go to one of the pathologies here, you can see how the fluid sits in that space, right? It's in between the lung and the border of our rib cage. So this fluid isn't in the lung, or it's not outside of this external barrier. It's between. So let's look into our case here. So we look at this case. So we can see quickly, let's do our search pattern so we can make sure we stay diligent. So right side, left side, come down, looks fine, come back up. And just real quick, since we're emphasizing this, the left causophrenic angle is pretty sharp. No lung pathology that I'm seeing here. And then we come up here, right? So the right causophrenic angle is gone. It's obliterated. It's blunted, as we would say. And this is the meniscus sign, right? This indicates that there's a pleural effusion. There's some kind of fluid. Now, we can't necessarily measure it or anything like that, Maybe somewhere in a textbook you can draw a bunch of arrows and do trigonometry or something, but that's beyond me. And then we come up here, so let's do the whole lung. We see there's a little opacification here. I'm not too sure if it's going to be relevant. And then we come back down and we go from the trachea, and then we see here. So otherwise, but you can see how this pleural effusion is actually obliterating the right heart border, right? So again, it's another way to silhouette because you're losing that air, right? And the silhouette sign typically is reserved for pneumonia, I like to think. But at the end of the day, you can at least see and appreciate that concept a little better here. Same idea, so we come across here and we can see very apparently there's something going on, right? There's something. And, we would think here, is this a consolidation? And the reason why it's not is you can't see that diaphragm. That's, it's blunted, of course, and typically you like to see a meniscus sign, but you're not really seeing that. But at the same rate, I mean, you can't see anything past this, right? In lobar pneumonia, you can actually see air bronchograms. You can actually see air through all that consolidation, right? This is too continuous to be pneumonia. And then we come back up here, go across, and you can actually see the patient somewhat distorted towards their right as well. But what's really important to note here is that you see this trachea coming straight down, and this is that carina. Remember that area where it diverges to the right mainstem bronchus and the left mainstem bronchus? This is also another clue in because this pleural effusion is so big that it's pushing away the anatomy. It has a mass effect, positive mass effect. It's pushing versus a negative mass effect. It's withdrawing, which is typically found in atelectasis. And you can see the lung here is a little bit more crowded, right? That's just from all that mass effect as well and shifting. So in this case, so we're moving on from the pleural effusions. Let's put this back up. So a known patient with emphysema presented with sudden onset of shortness of breath and pleuritic chest pain on waking. On auscultation, they had reduced air entry to the left. Sure. So we look at this and we can see the clavicle here. We notice something. It's a little off, right? So this patient probably had a right clavicular fracture and it's probably healed over, and that's why it's somewhat smooth and not a sharp angle being like an acute fracture. So it's probably a healing fracture. A callus formation is what we call that. And then we go to the left, all fine. And then we come down and we see immediately we notice something's off, right? There's just so much lucency here. Like we expect to see the vascular markings, and we're just not appreciating that. And so we go down and we can see here there's actually a hyperdense line, and that's actually the lung itself. So the lung is being compressed by this air coming in. And then we go down and we can see it's all the way continuous. And so this is a pneumothorax. And with the patient's history, put this back up, with bullous emphysema, sometimes there's a rupture and you can actually get air seeping out, and that comes out here and it can't be expelled. And so what happens, it traps. And this is something that needs an urgent remediation. And so we can see, we go down, go back up. Not too much else to notice. We see the lung here, or the heart here, excuse me. And then we come back on this other side and we're not seeing too much else. And so what's important to notice is that in this case, this was an isolated pneumothorax, likely from a ruptured bullous emphysema, some kind of blood bullae. And what there's known in radiology is a satisfaction of search. So you just want to make sure that you did find you found the key finding here. Great. But you want to make sure that you didn't miss anything else. And in this case, there's nothing else to miss, but just keep that in mind because that can be something that comes up. And then so here you can see after they put in the chest tube, you can actually see the resolution of the pneumothorax, that free air there in that space. Alrighty, so let's go to this case. So now we have a shortness of breath, no trauma. So go across real quick, come down, cut off angles, fine, come across, fine. And then we go on this side, it's like, whoa, what's this? And then we come up, it's like, whoa, what's that, right? So there's a lot of things going on here. This is like a trifecta of sorts, right? So we have air again. So this is going to be pneumothorax, right? Air in the thoracic cavity is pneumothorax. And then you see here, very flattened. And this is going to be a fluid accumulation. So there's a pleural effusion associated with this. And this is how you get a hydropneumothorax. So we're combining our words together. And then you can see here, there's the lung is all squished up, atelectatic or collapsed just from all that pneumothorax here, all that air. And then they potentially have a tension pneumothorax and could be decompensating. All right, so this case is a 45-year-old stabbing injury to chest, right? So that's pretty important. That's huge, and we're going to talk about that in a second. So clavicles, a-okay, come down. We notice immediately that the image potentially underpenetrated, right? It's not enough strength, quote unquote, where the chest x-rays aren't going through. And you see it's super bright. Costophrenic angle is fine. We see everything here is fine. Then we go back on this side, a-okay. And then we come back up here and it's like, whoa, this mediastinum is a bit widened, right? Normally it's not as wide like this. And so what we see here is that this structure here, something here is super bulgy, super big, right? And what tends to lie here, we talked about earlier, is the aortic knob or just the thoracic aorta as it becomes ascending to descending, right? And so the differential for this is fairly limited, being an aortic dissection, a thoracic aortic aneurysm perhaps, or some other neoplastic process just causing a huge mass. What I wanted to say before we move on is that, this clinical indication, stabbing injury to chest. Okay, that definitely gives us a clue into there's probably some pathology here, right? Now, beforehand, we did talk about a AP image, more mobile, portable, whatever you want to call it, supine, and how that can make the heart look bigger, right? We did talk about that. But in this case, could it look more emphasized? Perhaps, but there's a stabbing injury to the chest. And so this is why for clinicians, it's important for them to give a good indication. I mean, this is rather obvious, but a good indication for the study because it can help sway the final read, right? Sometimes you might say this would be normal in certain circumstances. Obviously, this is this is not normal, but the widened mediastinum could be a concern. But like as we saw before with the AP, it was widened, but it was actually normal. And let's see the case real quick. So we'll scroll down here. So this is the ascending aorta coming into the descending aorta, and then we see this patient actually has a dissection here. And that's what's causing the widened mediastinum. Now, in terms of clinical utility, not really much because, it's not as common to see. In terms of the boarding exams, this comes up like bread and butter all the time. They want you to know it. So just keep in mind when you see a widened mediastinum and the patient's decompensating or had some kind of crazy accident, that this should be something you think about. Alrighty, so for this patient here, let's see. So we're going to do our search pattern. So the anatomy is not in view, so it automatically makes the quality of the image lower than usual. But fine, we work with what we have, and then we come down. Not seeing anything. The costophrenic angle looks relatively fine. It looks a little funky, we'll say, but otherwise fine. Pulmonary vasculature, again fine. And you can see how this looks normal. Costophrenic angle looks a little weird, but it's fine. It doesn't look as blunted, perhaps, but we go across, come down, and there's not much more to remark. And you can see the mediastinum, how much different it looks like comparatively to the other patient. And so again, with great clinical history, which radiologists are also expected to go do their due diligence and look at the patient's chart as well, can see that this patient has COPD. And why that's important is because in COPD, chronic obstructive pulmonary disease, well, there's chronic obstruction, and so air gets trapped. And so if we were to count this patient's ribs, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, maybe even 12. There's way more than 9 to 10. Right, so these lungs are hyperinflated. And so this would just be hyperinflated lungs. This is important, a common thing to see in a hospital. And typically with those findings, you'd expect to see the diaphragms are flattened. In this case, it's a little ambiguous, but nonetheless, counting the ribs, you can clearly see that this patient has hyperinflated lungs. And then same thing with this patient. Let's see what they have. Humeral head's fine, chromioclavicular joint, clavicle come across, all good. And then we come down, and then we stop. We see something here, right? What is that? That little line there. We're going to zoom in, enhance, and what is that? NCIS or something. So we see here there's a fracture. So there's actually a patient fractured a rib. We would have to report that, obviously. And then we come down, the angle's fine. Coming back up, nothing too much else to note. This side is fine. Come back up and down. Come back here, trachea, right, left, no widening, heart's rather appropriate in size. And then one thing I did see down here, and just very briefly, you can see the cartilage is a little prominent. And it's just calcification that happens when you get a little older. In this patient, the key finding was obviously there's a rib fracture, but they also have hyperinflated lungs, and eventually you have an eye for it. This looks more inflated. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So again, you can see that as well. And then where they have history since they fell, right on the left side. Examination, no wound or swelling, but otherwise has that. And let's see. Yeah, they show that too. Alrighty, 6-year-old male coming in for acute onset shortness of breath. Search pattern, go. Looking here, going across, coming down. You can see cosophrenic angle is actually there. You can appreciate it. Maybe a little difficult, but you can appreciate it. And then we come up and we see all this opacification. It is continuous, so we can call it consolidation perhaps. And then we go back down. You lose the heart. So again, that silhouette sign is present. You're losing this heart here. So that tells us there's an opacification there. It doesn't tell us necessarily what it is. It just tells us there's something in the lungs that should not be there. The lung pathology, right? Interstitial opacity, consolidation, atelectasis, nodules, and masses. So this certainly doesn't look like atypical pneumonia, right? The interstitial opacity, the hazy appearance. Yes, it is hazy in general, but it looks more of a consolidation because it's continuous. It's all together. And so that was the left side. We go to the right side, and the cosophrenic angle is still there. You can actually see it pretty well. And then come back up, and you can see there's just a lot of all this, right? It almost seems like it's in a certain distribution. This perihilar is what they would call it. And this is a bat-winging appearance of cardiogenic pulmonary edema. Mouthful. But what all that being said is that in pulmonary or cardiogenic pulmonary edema, the congestion starts mostly at the pulmonary arteries, veins, here depending on the pathology, so the pulmonary veins. And what happens is all that pressure and all the congestion, all that starts to seep out here first. So this is actually an early sign of congestive heart failure, acute congestive heart failure. And then it has its distribution first. And then eventually it starts to become more diffuse, and you can see curly B lines, which are, those lines that go across here, and maybe we'll see some later. And that's also another sign of interstitial fluid. And then another key thing to note, clinically at least for patients with acute congestive heart failure, is that their image, they typically look pretty bad. And then after you give them some furosemide, some kind of diuretics, you diurese them, control their sodium, control their, monitor their weight, eyes and nose, and all that good stuff. And then their imaging looks better really quickly. Pneumonia will not do that. So that's another key finding here. Now you compare it to this patient who has cirrhosis and multi-organ failure, quickly going across. And then we see there's just a lot of opacification here, right? It's what we'd say diffuse, because it's diffuse, it's everywhere. It's not necessarily multifocal, or it's not like one here, one there, one here. It's just everywhere, right? And so in this patient with cirrhosis and multi-organ failure, this is acute respiratory distress syndrome secondary to perhaps some kind of sepsis or whatever's going on in this patient. And you can actually see here in their trachea, right? If you did your search pattern, you can actually see here there's a hyperdense structure. There's a structure in the trachea that makes it not so aerated. And this patient's intubated. This is the endotracheal tube, okay? And so real quick, we'll discuss in terms of correcting tube placement. If the tube is going into the right main stem bronchus, you have to pull back. You have to urgently pull back, right? And so that's why you always grab a chest radiograph after inserting an ET endotracheal tube. And then you can go here, and then you want to see that the tip of this is within 5 plus or minus 2 of the carina. And I can't measure it here, but I'm assuming somebody else did. And you determine whether you need to pull back more. Nonetheless, you can see all this consolidation here, this pulmonary edema, and you start to lose the heart, right? You can faintly see it, but you can still see the lower aspects of the lungs here, or the diaphragms. And let's see what happens with this. So again, you can see all that gook, and all that gook being the better word, a pacification, right? That's what we say for our thingy, but we don't know what it is, or we're just trying to sound like we know what we're doing. And then in this case, this opacity is consolidation, right? You can see how it's all together. It's all confluent. There's even air bronchograms. Harder to appreciate on the chest radiograph. Next one, so this is a 6-month-old coming in with cough and increased worker breathing. So this one I included because this comes up on the USMLE board exams. So this patient here, what stands out to us is there's this opacification, right? There's this thingy. We don't know what it is, but it's an opacification. So they have this, and it looks like it's lodged in their left main stem bronchus comparatively to their right main stem bronchus, which is patent. And this is still patent. You can actually see behind it, but it's just the fact that it's not obstructed. And so with that being said, you can see this lung looks a little different compared to this lung, right? How would you describe it? And I have you think about it because, that you already know the answer to what's going to be coming up here is that this is all air. And it's not as a pneumothorax idea, but as in there's air kind of being trapped, almost like a sense of COPD, right? Instead of chronic obstructive pulmonary disease, is it acute obstructive pulmonary disease in that sense, where all the air can come in because we have more muscle to inhale versus maybe perhaps exhale is a little bit more, we rely on that passive recoil, right? And so you can see the lucency of this lung versus this side here. It actually looks a little bit more potentially crowded, perhaps. Nonetheless, it's fine, but it's just definitely does not look as lucent as the other side. That's a key finding. Again, this comes up on the boards. And note that just because this happens to be a tooth, this could be a pea, this could be a peanut, whatever it's going to be. Sometimes you may not actually see what's obstructing. And so, in the absence of this, you would still need to know that this lucency is due to some obstruction, especially in a pediatric patient. There's very few things that are going to cause a pediatric patient to present like this. So quickly here, we see the lung, look at the bones, come back down, looks fine, come back up. You see here, and then as we go across here, we see that there's something here. There's an opacification. Again, I'm always going to say that word because you can't go wrong. So there's this opacification, and we do see that the trachea is a little bit skewed, but this opacification does not look like pneumonia. There's no case of pneumonia where we see that it was like very vertical, right? It's very weird. And so in this case, we think about our lung pathology. So is this an interstitial opacity? Does it look hazy, like a faint haze? No. Does it look like a consolidation? Potentially, but the distribution is very off. And then if we go to next aspect of the ICAN mnemonic, atelectasis, it actually presents like this. And atelectasis has a kind of predisposed way that it likes to collapse. Well, not in this kind of video, just because it's a bit more advanced and difficult to appreciate. But this would be atelectasis, right? Because if we go to our last aspect of the ICAN mnemonic, it's the nodules or masses. And this baby could be a mass that would be on a differential, potentially, at least unlikely. But this would given this distribution of way it looks wedge-shaped, right? That's how the lung collapses. And you can see here the trachea is actually skewed to this, right? Because the lung's collapsing on itself. It's that pressure causing it to come in. And then otherwise, last thing I want to mention here is the diaphragm is a bit higher than usual. The right diaphragm will always be elevated, well, typically be more elevated because of the hepatic dome that liver is compressing on top and pushing it up. But in this case, it's a little bit excessive. And there's actually a sign called tinting and more triangulation of the diaphragm as the atelectasis pulls everything upwards. Again, a little bit beyond the medical student scope. Alrighty, this patient, 35-year-old hemoptysis, left side protic chest pain. Okay, let's do our search pattern. Clavicles are fine, coming back down, and then we see this as opacity. And is it a consolidation? It almost looks like it, right? If you look closely enough, it's continuous. You might see an air bronchogram inside. I would like calling this a consolidation. It doesn't look like a little hazy smudge. It's not a atelectasis as we just seen, and then nodules or masses. It could be a mass potentially, but again, you're not really expected to see an air bronchogram. It's a little weird. And then as we come down, we see here potentially a pleural effusion, right? That costophrenic angle is rounded. We don't want to see it round. We want to see it sharp. And then same thing on this side. We come over here. It's not as sharp. You can see it. There might be something. Again, there's something to keep in mind. And then we go back up. Super lucent, but that's okay. And then we come down, go up, and then do a whole search pattern, and we can see we're still left with this consolidation. So consolidation, remember the differential for this was what? Pneumonia, pulmonary hemorrhage, ARDS, or pulmonary edema. Certainly not ARDS or pulmonary edema. It's just not the distribution for it. Is it a consolidation? Maybe. Hemoptysis left side pleural chest pain could be. I think further imaging may be warranted, and that's exactly what they did. And so if we scroll down on CT chest, scroll down here, let's see if we can find it. So we have here, there's actually an embolism here. And what we're seeing is actually blood. So this is alveolar pulmonary hemorrhage, essentially, due to a pulmonary embolism. So with that being said, the pulmonary embolism causes occlusion, area becomes ischemic, and it can infarct, but it also causes bleeding, and that's why the patient has hemoptysis. And so this is called a Hampton sign, Hampton hump sign. This is, I would say, clinically not going to come up probably ever, but it's very rare in that sense. But in terms of the board exams, it always comes up as a sly little question, and you just need to be ready for it. Alrighty, in this case here, we have a patient, 20-year-old male, fever, cough, hyperglycemia for 10 days and on antibiotics. So let's see what we have. So going across, coming down, and we see we have some opacification. So in terms of when we talked about a consolidation versus hazy opacities, right? It looks a little hazy, right? You can see here it's hazy. Maybe here's a little bit more consolidative, but even then you can kind of see through it. So all right, so this patient probably likely has some kind of infectious process going on here. Costophrenic angle looks appropriate, and then go on this side, costophrenic angle is appropriate, go back up, and we see this little hyperdense kind of outline, and this is actually a cavitation, right? And so you can see how the cavitation, when I mentioned that definition, thick-walled, and then there's some lucency inside. As we go up, nothing else to note, and then we come back down. You can see the right heart border is preserved, and then the left heart border is questionable here, but otherwise preserved. And coming down, there's nothing else to note. Let's look at the lateral real quick, and we can see the spine is dark, or hyperdense, bright, a little too bright. That's a little odd, right? And then it gets a little darker. That's good. And then retrosternal, dark, retrocardiac, dark. And then here, the heart looks too dark, right? Or excuse me, too bright. And again, this is knowing normal anatomy, you would be able to distinguish like, okay, this is too bright, so there's something going on here. And then we get a CT scan, and we see that this patient, on the right side, let's scroll up here. So we're scrolling superiorly. So let's look at the left side here since it's here. The air bronchogram, this was a consolidation, right? And it's of the upper lobe, and that's why we lost a little bit of that cardiac border. And even here, you can kind of see it. It's a little difficult to appreciate that border. You can see it here, but you can, determine why on a chest radiograph would be a silhouette sign. And we go more superiorly, and then here we go. There's this cavitation, right? Hypodense inside, very lucent, and then you see all this consolidation around it, thick-walled material. And I think This patient went on to have tuberculosis, I believe. Yeah, this was tuberculosis. And then a coronal, you see the same ideas. And then you can go here, all that consolidative material, and then we go back. Let's see, posteriorly, and there's your cavity again. That's seeing it in a different view. So a chest radiograph gives you the clue in. That's kind of like a quick, easy test, cheap test to see if we need to do anything else. Alrighty, so now we have this case here. So we have a 30-year-old male who is coughing. So search pattern, going across, nothing here, going down. We see that there's some kind of opacity here. Is it continuous? Yes, you can say, it is somewhat continuous, but you can see through it, right? It's not entirely a consolidation. It's a little bit more hazy than it is something that you can't see through, right? Consolidation, you can't really see through it. Okay, so the cosophrenic angle is fine, coming back up. And then we notice here that this is a little off, like the pulmonary vasculature. Sometimes, yes, it is prominent, but it's a little too prominent. We'll talk about that in a second. And then you look on the other side, same ideas, looks fine. And then we see here, again, a little too prominent. Come back from the top. Mediastinum is a little widened, a little bit more widened than usual. Again, the way to know that is by seeing a bunch of normals, and you can go from there. But what this essentially ends up being, this is hilar adenopathy. This is why this looks so big, right? The pulmonary vasculature is down here, but right here is a little bit bulgy, right? A little bulgy, maybe lumpy, one may say. And that's due to bilateral adenopathy. And this widened mediastinum is also part of the idea of losing this peritracheal stripe, and then part of the sarcoidosis picture. So this is sarcoidosis. And this opacity, this is one way that sarcoid can present. It can present pretty weird with how it looks on the chest radiograph, but nonetheless, you rely on the adenopathy and then some more clinical history. And I think some of these images, you can appreciate that those lymph nodes, right? And so that's what lives in that area. Alrighty, so this patient here, search pattern, going across, there was a little hyperdensity there, but that's maybe a calcification, it's fine. Coming down, and we notice that, okay, there's this hyperlucency, but is that the gastric bubble? And the answer would be no, because is this the gastric bubble? Is it colon? And colon maybe down here, maybe this is the gastric bubble. But we see there's this error here, right? There's something weird here. So we see that, and then we go across, we see it's still there, come back up, and okay, maybe not too much else to comment on, going across, no adenopathy, you see the mediastinum is not as widened as the other one was, and what this ended up being is pneumoperitoneum, right? There's air in the abdomen, it's air rises, and this is how you can see that, it's right below the diaphragm. And the clinical history, this is so beautiful, right? Diagnosed appendicitis, okay, post-laparoscopic surgery, x-ray was advised. So what I meant by it's beautiful is that we have a clear etiology of what could be causing this, right? They just had surgery. So it's not too surprising that they could have free air. Now, if you say someone just came off the street and they were coughing and you see this, you're like, whoa, what's going on? Like, we don't know what's causing that. We need to do more imaging. And then it is just the arrows showing all that. So that's the free air. Alrighty, so now we have another case. So a 6-year-old male, fever 2 days, another post-operative patient, okay? Hint, hint. So looking here, coming across, coming down, and then we come up. So, when you question if the lungs look normal or not, right? Let's count some ribs. 1, 2, let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So, okay, so it's an appropriate inspiratory volume. Fair. Looks a little crowded, but otherwise doesn't look like there's any consolidation. Gastric bubble, sure. Coming across here, got cosophrenic angle is appropriate. Coming up, coming down. Yeah, okay. See this. Okay. Is that something? I don't know. We can come back up, come down, trachea, and then the bronchi. So in this case, this is pretty challenging because this little area here is actually free air. That's a little challenging, but I included this to show you that this is also like how little air it could take. This is how the most, I would say, trickiest of presentations. The other one was pretty florid, right? There's no question of, okay, yeah, that's free air, right? This one's like, huh, like makes you think a little bit because that could look like a rib. It can look like interstitial markings. It could look like the pulmonary vasculature. And then, the lateral, perhaps you could see some air. But otherwise, it's not really too crazy, perhaps. And so that patient did end up having some a uh, pneumoperitoneum. Alrighty, 6-year-old male, shortness of breath, fatigue for several months. Okay, let's do systemic, going across, or systematic. Down here, coming up, nothing. See this. This is a little odd. What is this, right? We know the heart shouldn't have a hyperdense ring around it. Is it around it though? And then we see it, and then we see here, where's that gastric bubble, right? It's displaced a bit. Okay, that's a little odd. Why is this here, and why does it look like it's coming up into this area? Okay, so we're thinking about that for sure. Let's go back to that. So we come up here, let's see a little something here, perhaps subpleural, and then come back up, down, and then as we go down here, nothing too much else to comment on, and so we're left with whatever this is, right? So we see this air, this gastric bubble kind of creeping up, and then you see this, and you're like, oh wow, like that, yeah, that's coming up, that's in there, right? And so this was actually a hiatal hernia. So the gastric, the stomach is actually coming upwards past the esophageal diaphragmatic junction, and coming up, and you can actually see it looks like it's behind the heart, in front of the heart, whatever. It's a 2D image, it's hard to determine, and so that's what this hiatal hernia looks like when it's slipping up. And then this is another case of the same idea, and you can see here it's this pocket of this little air bubble, right? That shouldn't be there, right behind the heart. It looks a little bit dense. We see the gastric bubble is absent, and then that is our another hiatal hernia. So almost closing out to the last couple cases here. So we have a 6-year-old female, known and operated case of left breast cancer. Okay, fair. I'm not sure if there's any clinical indication, beyond that, if they're coughing or anything, but for educational purposes, it'll help. And so search pattern, go, we're looking, not seeing anything crazy, coming down, coming up, fine. You see, it looks a little, like a little bit more hyperdense, a little bit more opacification. And we go across and see here, coming up, down, and not seeing anything crazy, right? And what we do appreciate though from this history is that there is a right breast tissue, mammary tissue, and then the left is not as defined. And this patient ended up having a mastectomy, but they also had an implant. And you can actually appreciate that here. This is the patient's implant versus their native mammary tissue. So I include all that to show, sometimes you have to be vigilant and see that there is a difference. We get so caught up looking at the lungs and looking for what we want to look for, our confirmation bias, that we do miss this. And then had you not paid attention to that, or if these people didn't give us the greatest, at least indication here to let us know that there's breast cancer, we wouldn't be able to appreciate the fact that this opacification is actually normal and not an atypical pneumonia or some kind of other hazy opacification. Okay, so now quickly we just see here, immediately you can tell there's something going on. There's something. There's all these little round things. So let's go through our little mnemonic. ICANN. Are these interstitial opacities, are they hazy, reticular, nodular? Nodular being very fine? No, that's not. Right? Is it a consolidation? No, consolidation isn't so well circumscribed. And then atelectasis, definitely not. So we're left with nodules, and we have nodules and masses. So remember, nodules are less than or equal to 3 centimeters, and then mass is greater than 3 centimeters. And so you clearly have a mix of that. So this is multifocal bilateral nodules and masses here. And this patient actually had, I think it mentioned, thyroid cancer. So these are actually metastases. And these are known as cannonball lesions. These can be seen in a wide variety of metastatic disease. So from breast cancer, venous cell carcinoma, potentially some other cancers as well, but those are the main ones, and thyroid being what this patient ended up having. And then we see in this patient, so 65-year-old, background Crohn's disease and immunosuppression. Immunosuppression is always one that should catch your eye. So coming across fine, hyperlucent for sure, but we come down and we see this, right? This certainly looks like a cavity, right? It's got that round, hyperdense line around it. We go more inferiorly, consophrenic angle's fine, come back up. There's maybe some hazy opacification here, but nonetheless, we definitely see this cavitation. On the other side, there's a little bit of atelectasis beyond the scope of this video. Come back down, and we don't appreciate much else, but we definitely see this lung abscess, or this is what it ended up being. But in the case of this, you would have a differential of some kind of cavitary disease. A patient with immunosuppression, you're definitely worried about some kind of disease, and you can actually see the fluid accumulating within this abscess. So immunosuppression, you'd be worried about fungal disease, or some kind of other disease that takes advantage of immunosuppressed patients. So let's see here. This is the patient. I believe this was after resolution. 5 weeks. This is a 5-week previous. So this is previously what they look like. Clearly different. And then you can see there's hyperlucency. So probably some component of COPD or some other cause for hyperinflation. And then let's just scroll down. You can see there's some hazy opacification, some ground glass opacities. This is a pleural effusion, and you can actually see here this big old cavity, and you can see the fluid inside as well. And so that's the lung abscess that we're seeing. And then this is the consolidation near it. Alrighty, 2 more cases. So we have here, let's see, 6-year-old male losing weight, and they have a chief complaint of otherwise cough. So coming across, nothing to note, bones look fine, coming down, and we have another little cavity, right? And you can kind of get the hang of it now. You see that little fluid level. There's something in there, whether it's pus, blood, exudate, we don't really know. And then you can see there's a consolidation near it, or there's some kind of opacification at least. And then we go down, nothing here, nothing there. Go back up, come across, and otherwise fine. So this patient here, let's see the lateral, and you can see that where it locates. Let's see what the next image is going to show, and it just shows the idea. So this ended up being, it got biopsied, and it was a cavitating lung cancer. So squamous cell carcinoma can cause this, and for a medical student, just know that for lesions that are peripheral, those are favorable for biopsies versus something more medial that can be accessed by a bronchoscopy. That's how they'll take their sample. I believe this patient was sampled from a biopsy. I think I had it read. Patient went on CT, and biopsy confirmed the presence of squamous cell carcinoma, right? So, and then this is our last case. Take a good look. See what you see. Pause it, think, great, you came back and you found it. So we go across, we go down. Let's see what their indication is first, sorry. Patient has a history of smoking, was referred for chronic cough. Okay, so they have a chronic cough. So, all right, 70-year-old male, chronic cough. This is definitely, giving me some concern for maybe some kind of malignancy. So left lung looks pretty fine. Pulmonary vasculature looks a little funky, but maybe they're normal. Otherwise, nothing else to remark. Coming up, coming down, coming up. Whoa, what's that? Right, so there's something here, and it's round. It doesn't look like a cavity, so it must be a nodule or mass. Visibly, it looks like it's probably going to be a mass, right, greater than 3 centimeters. And then we come down, pulmonary vasculature, and then nothing else to comment on. So this looks like malignancy, right? Let's see what this one shows. And here's our measurement, our green line. So it's just, round up, right? It's a mass. However, let's see. So this patient was referred to a cancer center for suspected lung cancer. So let's scroll down. This isn't really a window for the lung tissue, but let's just see if there's anything that strikes out to us, and there's not. And what's interesting is that what we were seeing here, so remember, we saw this here, right upper lobe for sure, was actually something posterior, something under back, was a lesion under back. And I think it was probably like a lipoma, super common. Extrapulmonary location. So I don't know, they actually identified it, but a lipoma is pretty common. You know, these kind of some kind of seborrheic keratoses. You know, if you think about neurofibromatosis, type 1, those patients have an abundance of them. And you can see that on the imaging, and that's something to keep in mind here as well. So a test radiograph is a 2D image, so we need to get more context clues, okay? So, well, that was our final case. Hopefully you found the video instructive, super long, but hopefully instructive. At this point, I think it would be beneficial to explore any content that will help with your comprehension, or explore cases on Radiopaedia to get some repetitions, so you can get familiar with what's normal versus abnormal. But otherwise, that's all I have today, and thanks for watching.